35 years ago, I started my career in neonatology by joining the lab of Dr. Ola Didrik Saugstad, which may sounds well known to some of you. He was the guy who introduced the thought that maybe it was harmful to resuscitate with oxygen, as we used until 2010. We were resuscitating piglets with either 100% oxygen or room air after experimental asphyxia. Back then, in 1990, about that, pure oxygen was considered absolutely necessary to oxygen was considered absolutely necessary for resuscitation of newborn infants, and even talking about using room air was quite taboo. In 2010, as many of you will know, after 20 more years of research, these recommendations changed to start with using room air, as we still do. To get there, we used the classic reductionistic approach, assuming a linearity between the amount of oxygen used and the outcome, as you see here in this figure. This method works well when there is a linear relationship between cause and effect, and when we also have the ability to correct for confounders that we know about. So, at first glance, using the same method may seem quite reasonable if you are studying effects of PDA closure or interventions to prevent BPD. For more than 40 years, we have been doing research and we have published thousands of papers without being able to actually answer the question of when, who, and how should we actually close the PDA in a preterm infant. This could, of course, be due to several reasons, like poor study design or protocol violations or selecting the wrong group of patients. But there is also another possible explanation for why we don't still haven't been able to answer that question. It may be that the assumption of a linear relationship between closure and outcome, which is actually the premise of this type of studies, may just not be true. Look at this figure. Imagine that each of these small points, the circles, represents an intervention which influence the outcome of the patient in the middle. Each of these events both modifies and are being modified by all the other events. It's a complex web of interactions, which is quite difficult to make sense of when you see it like that. The journey from preterm birth to discharge, or 10 years of age, may look much more like this web than the single cause-effect linear relationship you saw in my first figure. Premature birth includes months of treatment with rapidly changing organ maturation, 20 to 50 minor and major daily interventions, care by different doctors and nurses, and a large panorama of disease manifestations. Prenatal and postnatal care, as well as parents' ability to nurture. Cognitive development differs between patients and between populations. An infant requiring long-term intensive care may be described as a complex adaptive system. It adapts to external physical stimuli or internal biological stimuli by triggering feedback loops, by feedback loops triggering biochemical, physiologic and immunologic responses. Some of these responses we may know fairly well. Others may still be unknown to us. But add to this that in preterm and severely ill infants, our knowledge of how responses interact and balance each other are nearly non-existent. Neonatology has one of the most complex patient courses in modern medicine. The number of confounders and how they interact are beyond any statistical method of correction. And complexity disrupts the linear relationship between cause and effect. Or to say it differently, in a complex system, the output is not predictable by knowing the input. So, look at this little red spot here. If this little red circle represents closure of the duct, it should be easy to see that the effect of closure is not linear and instead may be modified by countless other events before a final patient outcome becomes visible. A consistent effect on an outcome may therefore be difficult or even impossible to measure, assuming a linear relationship. It's therefore due time to acknowledge how complexity profoundly influences outcomes in neonatology and changes our understanding of how these outcomes are generated. So, my first challenge to the next generations of neonatologists is this: to better understand what's important and what's not to the outcome of neonatal intensive care. We may need to change our current model of how interventions and outcomes are related and start exploring new methods and technologies like the one you heard from Peter Lawson earlier today to make sense of the large amounts of data collected continuously throughout the complex course of neonatal intensive care. So, to my next challenge. 15 months ago, I became the grandfather of this little girl, Olivia. She was born in week 33, and she was admitted to her local NICU, given a full 7-day course of antibiotics, despite no risk factors, no clinics, and no lab data indicating infection. After 3 days, she repeatedly tried to rip off her CPAP mask, which from the neonatologist grandfather's point of view seemed quite reasonable as a reaction to unnecessary treatment. But I kept my mouth shut to avoid being the annoying relative. And she ended up using it for 3 more days, protesting heavily. Her father, who's sailing around the world as first mate on large container ships, asked me my opinion. And I told him that I would have probably stopped both antibiotics and CPAP after 2 to 3 days. His comment was, so you had the same CMA attitude in medicine as I had to deal with at sea. I'm a Norwegian, so I didn't understand what CMA was, so I asked him. When he replied, it means cover my ass. Yeah. I think we all may recognize ourselves in this story. We do things not necessarily because it's in the best interest of our patients, but to avoid being criticized by our colleagues or even worse, face legal claims. In practice, you will rarely be criticized for doing too much. But the risk is real when the wise guy in your unit comments that maybe you should have added another inotrope to the 3 you were already using to treat an infant with septicemia. This culture leads to overdiagnosis and overtreatment, which is not harmless. Treatment with no effect on the disease that you are treating may still have severe adverse effects. We used to think about medical practice as rational and guided by research, textbooks, guidelines, and the wisdom of experts. But most of us are not aware of how flaws in judgment and irrational decision-making may significantly affect outcome in our patients. Yeah, look, if you doubt what I'm saying, you should take a look on these two books. They are written by the Nobel laureate and behavioral psychologist Daniel Kahneman. And you may be surprised to learn what research has actually taught us about our ability to reason logically. We may be experts in medicine, but that doesn't make us experts on logical reasoning. Flaws in human judgment also contribute significantly to large variation in how we provide healthcare, independent of morbidity and socioeconomic differences. This has been documented through the Dartmouth Health Atlas for US during the last 30 years in all kinds of types of medicine. In 2016, we published the Norwegian Neonatal Healthcare Atlas. And in 2019, the Dartmouth Health Atlas of Neonatal Care in the US and Norway was published. I shall explain what these atlases show. By counting services used by patients within a defined geographic area, rather than what's provided by a specific NICU, we get a population-based estimate of what use of health services looked like in that area. And we also avoid the case mix problem, commonly experienced when comparing activity between NICUs. In Norway, you see here, the overall admission rate varied between 7 and 16% of all newborn infants. If you look here at the right column, you see this is each dot represents one geographic area. You know, Norway is a small country, only 5 million people. We have 15 NICU areas. But each of these dots represents the percentage of admissions. And if you look at those below 34 weeks, you see that the variation is very small. It has an extremal ratio of 1.2. So that's negligible. But as soon as you go to those between 34 and 37 weeks, extremal ratio increases to 2. It means that the highest admission rate and the lowest, there is a 100% difference between them. And even more, when you come to babies over 37 weeks gestational age, then the extremal ratio increases to 2.6. So why is that? Okay, you can imagine why it's small in the 34 weeks, because if you are not admitted to a hospital, you either die or you get severely ill and have adverse outcomes. So we all are admitting babies at that age. But when you are above 37 weeks, you can think about it yourself. It's very preference sensitive. One doctor may think that this is necessary to admit babies breathing 50, 60, 70, and another one says, okay, we can wait and see. So there are big preference differences, and that's important to understand. Large variation in rates was also seen for ventilator treatment, antibiotic use, and the number of intensive care days. So here you see the US Atlas, and this also shows admission, but infants with birth weight about 2,500 grams. The darker the color on that map, the higher the admission rate. And in the US, actually, a 5-fold difference was seen for normal birth weight infants. The same large variation was also seen for chest and abdominal films, head MRIs, and special care days. These two atlases are freely downloadable on the net, so if you're interested to take a look on what it looks like, it's quite interesting. There is one factor in the US that it also contributes significantly, and that's what we call supply-sensitive care. If you make up the number of NICUs in the area is very closely related to admission ratio. So the more NICUs you have, the more infants are admitted. And that doesn't mean that those who admit the most do necessary care. I guess you can imagine that. Okay. Most of us probably consider our current practice as being evidence-based. But is it really? How many decisions during your daily rounds are based on reasonably good good evidence? And do we have, for example, what's the evidence for the number of blood tests you are ordering each day, or the number of chest X-rays? To my knowledge, the evidence equals 0. I have never found anyone trying to do that. 20 years ago, I launched a PDSA project in an attempt to reduce the number of blood tests and X-rays in the NICU where I worked at. And here you can see what happened. After 10 years, the number of blood samples per patient decreased from 18 to 5, and the total number of radiology procedures decreased from 2 to 0.84, more than 60%. It's also worth saying that we didn't observe any adverse events due to this change. I would be surprised if anyone here disagree with me if I say that newborn infants should not have blood tests taken or be separated from their mothers due to NICU admittance, if it's not absolutely necessary. But what is necessary? That's the big question. It's not possible from these utilization rates and health atlases to decide which is the better rate. But from a resource point of view, a lower rate resulting in similar outcomes as a higher is more efficient, and a rate reflecting necessary treatment without exposing patients to the risks of overdiagnosis and overtreatment also indicates higher quality. For Norway, there is no indication that the lower admission rates exposes infants to the risk of adverse outcomes. So, my second challenge to the next generation of neonatologists is this: how can you avoid overdiagnosis and overtreatment without risking adverse events? Impaired neurodevelopmental outcome following neonatal intensive care is still a major problem. Little high-quality evidence favoring one specific treatment strategy or another exists with respect to long-term outcomes. However, the evidence base supporting differences in short-term and long-term outcomes depending on how we provide care is actually growing. High maternal involvement in care results in improved cognitive and language scores at 18 months. Using a parent-infant transaction program increases IQ at 5 years. Skin-to-skin care reduces stress and pain during procedures, improving cognitive outcomes. If the documented benefits of parental participation could be achieved using a drug, it would, without question, have been standard care for all infants, in line with how we use caffeine and breast milk fortification. Unfortunately, this drug doesn't exist, but parents usually do. We performed a control study between a new single-room unit allowing parental presence 24/7 and an old-fashioned open bay unit that also allowed unlimited parental presence. We found that if you This was in babies between 28 and 32 weeks gestational age. And what we found was that mothers in the single family room unit used 21 hours a day together with their infant in the room. And the fathers, they used 16 hours a day compared to the open bay unit, which was also fairly good. But that shows that if you allow parents to have unrestricted access and you are facilitating it, they want to be with their baby all the time. Yeah. In addition to the satisfaction of being with their infant, parents were also rewarded with less symptoms of depression and stress compared to the controls. So they don't get stressed about being together with the infant. It's opposite. Unrestricted parent-infant interaction also brings neonatology in line with how developmental psychology understands infant brain development. As a result of the quality of the physical responses and the social interactions experienced by the infant. Today, we may have reached a level of knowledge about how stress, pain, and absence of positive stimuli do harm that no longer justifies how we provide care. In the NICU, we had the privilege to observe and support the beginning of the two most important relationships human beings establish throughout their lifetime. The relationship with our parents and the relationship with our children. What does that mean? Could it be so that by directing all our attention towards the strict medical interventions that we like so much, we may be barking up the wrong tree, missing where the real potential for improvements in long-term outcomes actually may be found. My last challenge to my future colleagues is this: how do we create a culture of care that really allows for parental participation and unrestricted parent-infant closeness in a highly technological intensive care setting? Finally, I would like to tell you the story of Abel, who was 28 weeks gestational age, together with his father. His father was a biologist, and from day one, he spent hours doing kangaroo care with Abel. After being discharged, he published an essay about his experiences in the NICU. And what he tells us says something important about what's going on, literally right under our nose, every day in our NICUs. You can read it for yourself. Thank you for your attention.